discussion is over now. Now let's proceed to our next session, which is on GIST. And our moderator is Dr. Ramanuj Mukherjee. Thank you.
Can I have the screen, please? Right. A very good afternoon, ladies and gentlemen. I think we'll be having the last panel of this beautiful conference. And the topic may appear to be a bit futuristic for many people. Believe me, with the amount of GISTs that are being diagnosed and are being encountered, this is definitely not a very futuristic topic now. It is in reality. Welcome to the city of joy, Kolkata, and what we will try to give a message from our panelists should not be very controversial and should be something that will change your practice. Now, I will request my panelists to be on the stage. Dr. Amit is a medical oncologist. Dr. Amit usually practices across many hospitals, predominantly being in Apollo. Dr. Girish is a GI surgeon based in Astor RV. Dr. Govind is a GI surgeon associated with the Manipal hospitals. Dr. Manisegaran was expected to join. He was from Yasoda Hospitals, Hyderabad. Could not join, unfortunately, today. Okay. So with this and with my distinguished panel in seats, now, if I had residents, I would have explained them that when we were students or when we were residents, we actually were in a phase where GISTs were called as leiomyosarcoma. So that's a long time back, around 2 decades ago. Now gradually people understood that there is a cell called as the interstitial cells of Kayal, which were the pacemaker cells, which came on to become something which led to a new kind of a tumor, a neoplasia, called as a gastrointestinal stromal tumor. Now, a mic for them, please. Mic de dijiye.
The slides are not coming.
Slides are not coming. Okay. Now, what happened was that over the last 20 years now, the GISTs has been technically a poster boy for something called targeted therapy in solid tumor. Believe me, and over the evolution that has occurred, the only thing that I wish to draw your attention is to an article that was published around 20 years ago. As you can see, the last of the authors is a gentleman whose classification is still used by many residents to talk about the recurrences and grades of tumor. But this article has more than 3,500 citations now, was something that told the world that yes, there is a drug called imatinib, and that is something was the beginning about the use of drugs. Now when you come to recommendations and guidelines, something that our panel of experts will be talking about, NCCN, or the National Comprehensive Cancer Network, initially 5 years ago had GISTs as a part of their sarcoma guidelines. Gradually they understood that surgeons and oncologists were now dealing with it on a more frequent basis, and it became, as I have said, the poster boy for targeted therapy, so much so that if you see the NCCN 2022, they made a separate line for neoadjuvant therapy, something that we are going to discuss. And when neoadjuvant therapy fails to regress, what happens when the disease progresses? Parallel to the NCCN, on the other side of Atlantic, the ESMO, the European Society of Medical Oncology, and the European colleges again prescribed imatinib with a 6 to 12 months duration. So with this background, I would like to start the discussion with Dr. Govind. Dr. Govind, you see, we as surgeons, to start with, the first is, before we talk about neoadjuvant, let us have a few words about what are the principles that you will follow or you do follow when you talk about an upfront surgery. Like what are the margins, what are the principles, and how do you manage lymph nodes if there are any? Please.
So the principles of surgery are slightly different from adenocarcinoma surgery, which is done more commonly. You don't really have to do a lymphadenectomy, number one. Number two, if you're any R0 resection is probably sufficient, and you don't need to, having said that, generally if I have room to take a larger margin, then I do, like if it is in the greater curve of the stomach. But I wouldn't take out an additional organ or take a risky resection just to get additional margin. Negative margin for me is sufficient. And I think these are the two most critical things. And sometimes if it is in a tough location, you could also biopsy it, and I'm sure that you'll come to it later in the presentation. Yeah. But the idea is you don't want to be too aggressive with the resection.
Right. So if this is so, then what is the margins that you usually take, Dr. Girish? Sir, what are the margins that you usually like to have when you are dealing with a GIST?
1 centimeter margin from the palpable lesion is good enough. And with that we can preserve the organ. We can go even endoscopic or even laparoscopic resection.
So that is probably the reasons, like that GISTs on the greater curvature around 2 centimeter in size, we have been very successful with the laparoscopic repair. Okay. Now, Dr. Girish again. Dr. Girish, when do you consider that taking out lymph nodes, say at least doing a D1 dissection, should be good enough for a GIST?
Pardon? I didn't get
When
that.
will you like to take out lymph nodes additionally, or any role of lymphadenectomy?
It's only if there is an extension directly, then only we should consider. Otherwise, there is no role for a radical like a D1, D2 kind of lymphadenectomy. It's only if it is adjacent and it's invading into that directly, rather, that is an indication.
No, because as a surgeon, this is our thing, but when we had a talk with my medical oncology guys, they said that Ramanuj, you see, nowadays we understand GISTs by their signature of mutations. So if it is a succinate dehydrogenase, they recommended that it is better that you do consider somewhat like a D1 dissection. So that is a new thing that I learned, sir. Okay. Yeah, Amit, we will come to you, sir. Now, Amit, you have your show. Yeah. Because let us surgeons have the initial chat. Right. Now, whenever we talk, ladies and gentlemen, about GISTs, and as Dr. Govind and Dr. Girish told you, see, we surgeons understand that acha anatomy, something that we can take out, and bad anatomies. Now, I would like to ask Dr. Govind. Dr. Govind, what are the things that you do consider that good, that you can go for an upfront, and what are the things that are bad, that you think that, yes, I need to involve Dr. Amit as a medical oncologist?
So to start, I would say all our cases would be discussed with the medical onc team to make preoperative decisions. But generally, if it is low morbid operation without long-term sequela, then, like for example, in the first image where you have shared, where there is a greater curve involvement, there may be some colonic involvement. We don't know. We will only know at the time of but whatever it is that can be safely resected, probably doesn't need a stoma, probably can retain gastric continuity and colon continuity. So that would probably be amenable to upfront surgery. Whereas the second picture is maybe close to the GE junction. And sometimes these pictures can be misleading also, because it may be a fundic lesion that's pushing against the GE. We don't know is the thing till you start. So there you may consider neoadjuvant. Now, I think, having said that, two things are there. Going back to the first question, I think when we said you don't have to be aggressive with the resection, I think we should also add that supposing in the first picture the colon is adherent, then you should resect the colon with it. You don't want to peel it off. That was not my thing. So you want to achieve an R0 resection, but doesn't need to be an extended margin.
Right.
And I think it's better to get the medical oncologists involved in all the cases, but you may choose to operate early.
Okay.
Apart from good bad anatomy, I would also like to include the grade, because size is also part of the grade of the tumor. So when it is such a high grade, when it is more than 10 centimeter, of course the grade depends on different locations, 5 centimeter, 10 centimeter, and with a fantastic response to the neoadjuvant therapies. So why not give a chance? Why unnecessarily resect the colon? So in the first scan, so definitely it's worth considering in larger tumors. Apart from bad anatomy, these two I would consider.
So that means
Especially
that
in the rectum, if you go down to the
Right.
rectum again, it becomes a even anal sphincter preservation. All those things will come into picture.
So that means that the summary should be that whatever organs that we are talking about, we should try to maintain the continuity and maintain the physiology as much as possible.
Yes,
Very
yes,
good. Now, Amit, we come to you, the biology of cysts, because this is where the problem starts. Now, you see, as Dr. Girish has mentioned very, very rightly, that we are now in an era of understanding something called as a multidisciplinary meeting or a tumor board, maybe over a cup of coffee. Now, what exactly is your definition of a good biopsy, or how do you consider a good biopsy to be, Amit?
See, so, when I was reading, I found that if it is, good US guided, FNA where you can make a cell block, that should be usually sufficient. Then I also, when I digged a little bit deeper, then I found that more is the number of biopsy, usually, the yield increases. But usually the first biopsy usually gives you a yield of 93, and if you do even 7 biopsies on one specimen, it gives you a yield of, 96, 97%. So, but then, if first is good enough, you don't need the second, because, you need what you need is a good tissue,
Right.
where you can just ask your pathologist to opine on the histopathology, and you should also be able to do basic immunohistochemistry and molecular markers that I am sure
Right.
you will be
So that
discussing
will be
shortly.
definitely will be coming. Now, we'll be again coming back to organs in which it is not exactly sticking onto the lumen. Say like it's a big retroperitoneal cyst or a mesenteric cyst. Then what form of biopsy, Amit, will you recommend? Will you call your surgical colleagues to do a laparoscopic biopsy, or will you like to call your radiology colleagues to take a CT guided core?
I mean, see, in rupture of the gist is a bad, or ominous, thing, which you don't want, because they become from good to bad the moment you have ruptured the tumor, whether it is spontaneous or radiologically or surgically. So, it should be very careful, if, and in those cases where it's tough to do a, easy biopsy like endoscopic, usually we do involve our surgeons.
Okay. Right. Now, coming on to again, Amit, because this is a point that we surgeons will always depend upon you, the biology thing. This is the tough thing for us to understand. Okay. Now, you see, these are these mutations and all these tough things. Okay. Just what are the markers that should be sent from the biopsy specimen?
See, so, there should be a good pathologist first to do in the IHC, and, in IHC, what you want to do just is one marker like CD117. Because, in approximately 90% of them, they will be positive for that, and, if that is positive, that there is a KIT which is activated. Mutation might be KIT or platelet derived growth factor alpha, or sometimes, independent of that too. So, that should be mandatory, and each center treating just must have a facility to do at least this. But then, now the things have changed, as we will be discussing soon, that, there are molecular signatures which does determine what treatment, what neoadjuvant treatment should be done. It should be done at all in neoadjuvant or adjuvant treatment. So, ideally you should have a facility of, those molecular markers also, where they should be tested, particularly KIT and the platelet derived growth factor, and there is a role of NGS also, which is coming up to look into some fancy mutation where there is a drug for that, like BRAF and all those. So
No, so but in a routine practice, Amit, so after the diagnosis comes to be a GIST, say high grade, then is it your routine practice in neoadjuvant always to go for these molecular signatures, or can he bypass that and start with imatinib?
No, we do. Like, if there is any tumor which is less than 2 centimeter, we forget about that, because, in that situation, the surgery is the treatment and you don't need any other treatment.
Right.
When it comes to, say, more than that, say more than 2 centimeter and or, high grade tumor where there is a more mitotic count, you will ideally like to have a molecular signature for all. But then, that will change your decision in approximately 10 to 15% patient only. So, if that is not there, I will not crib over it, because that most of them will be responding to the imatinib eventually. But then you should have at least CD117 for most of them. And if you are lucky working at those centers where there is a, those molecular testing can be done, it should be done.
So
because in 15% cases,
summary,
you will change the decision.
That before we take a decision in the tumor board like this one, that we are not going in for an upfront surgery, we are going in thinking about that it's maybe a rectal gist close to the sphincter, and I do not wish to go for an APR, I wish to preserve the sphincter, go for an LAR, sphincter preservation. Now, as a part of a tumor board, what are the panel that needs to be sent or anything specific that needs to be written for that panel? Do you have any code or any particular thing to be written?
Yeah, we do write, sir. In those cases, at least you want to do, if it is a KIT mutation, whether it's in exon 11 or 9.
Okay.
Because if it is exon 11, which is the commonest, you will be giving the standard dose of imatinib 400. But if it is, say, exon 9, you want to treat them with a higher dose of imatinib, just like, 800 milligram per day. You want to know that. If it is, say, the platelet-derived growth factor alpha mutation, you want to be careful about exon 18 mutation, where you have this D842, mutation. They are not sensitive to imatinib, and if they are there already, you want to treat them in something else like avapritinib, which is available and recommended by ESMO and NCCN.
Right.
So
that
at least this should be,
for a summary then, if you are getting a GIST, planning a neoadjuvant, you should be sending for mutational receptor testing. Minimum exon 9, exon 11, PDGFRA mutations. Good. So with this now background, now the next to all of the three of you, you get a GIST, it has been diagnosed either on a CT or an MR. Okay. What is the recommended imaging modality before you plan for starting a neoadjuvant therapy? Okay. Dr. Govind, please, to start with.
So practically most commonly people either come with a CT or I get a CT. That becomes your kind of general evaluation. I don't commonly use a PET unless there is something specific I'm looking for, or if I'm, if there are some lesions that look metastatic but we're not sure. And the MRI is primarily in the pelvic region if I want more details of where the tumor is in relation to the sphincters, etc.
Yeah, I do agree with most of the points, but one advantage of PET is, though I don't recommend upfront, in the follow-up, because the response to treatment also can be assessed with the PET, whether it's lighting up or some new lesions within the solid lesion, if there are some lighting up points. So these things can be picked up. So maybe in the follow-up is very useful.
Okay, Amit, do you recommend PET before you start neoadjuvant?
Not always. If there is a good CT scan, because this has been proved beyond doubt by 2 RCTs that CT is as good as PET, but provided, we just don't look into the imaging part of the CT, we have to see into the density part of it also. So if density and other parameters are taken care in CT scan, that becomes as good as PET scan. But, as sir rightly pointed out, when you have to say, do a response assessment early, then PET scan may become handy in those cases, but usually they are of theoretical importance.
Exactly,
then
because that is something that we are going to come very quickly.
One more thing, if I can make point to, only problem with CT scan some cases that those liver metastases are iso-dense. And when they are iso-dense, then you have to do an MRI or PET scan to understand them better in the liver.
That is exactly the problem that I have faced. This is what I was discussing with Dr. Govind. I started neoadjuvant on a patient with rectal GIST, only to find 3 months down the line that there is a liver metastasis. Now I was very, amazed, because then we looked into the previous CTs to find out that there was a METS. So that is the reason. Now, Amit, but let us see another example. Say it is a bad biology. That means it is not that KIT or PDGFR, it is those rare variety of mutations. So still do you think PET should be done because the biology is bad? Or should a CT be good enough for the preoperative assessments?
I mean, sir, biology should not determine, what radiological modality we should be choosing from.
Right.
So I think we will be,
we'll be happy with the previous ones, like we did with the anatomy. Right. Now, because the reason about asking about biology is that because imatinib leads to a loss of the GLUT4. So that is actually the ACRIN trials, that is something that I was getting into. So because imatinib will lead to the loss of these GLUT4 receptors. Now, after we have had little bit of discussions and consensus, ladies and gentlemen, we now come to something on the controversial part. But before controversy again, what are the things that we have learned till now? Number one, this is what the NCCN and the ESMO says, when should you consider at all giving neoadjuvant in GIST? As my panelists have mentioned, Dr. Govind and Dr. Girish have mentioned it very, very importantly. When you are likely to get an R1 positive margin, you are expected to do an organ preservation, but you cannot. Or your opportunity is to preserve more of a stomach, less of a colon again. So that is the point, and it is marginally resectable. You should consider giving a neoadjuvant. Now, Amit, the controversy gradually starts. Which drug will you select? Because imatinib, sunitinib, and the nibs and mabs are unending now. One day I wish to find my name in maybe one of those mabs. Okay, so which drug are you going to select now?
Sir, there is no confusion here. Imatinib for most,
Yeah.
except, high dose imatinib, as I pointed out, for exon 19
Exon 9
mutation.
mutations, right.
And if you have those, PDGFRA D852 mutation, then evapratinib is a better drug.
Okay.
Because, that is what should be done. Sunitinib and regorafenib are the drugs for, subsequent line, and usually we don't use them upfront,
Upfront. Okay, the next one. So that's a very important point made. So there is no confusion that imatinib is the only drug till now. Okay. Now, Dr. Girish, your patient is being advised for an imatinib therapy. There is a rectal gist. Before you start the rectal gist on imatinib, what are the pre-therapy tests that you need to do more regarding any surgical considerations for rectal gist or G junction gist or a duodenal gist? Anything special that you would like to do? Any marker placements, anything like we do in a cancer, etc.?
No, it's not required. Like in the adenocarcinoma, actually, we have to treat when we do surgery. We have to do for the first imaging.
Right.
But it's not the same in gist, because it's more of expanding rather than infiltrating. That's what the bad image it gives when it is so huge. So it does not mean that we have to treat how it was in the first place.
Okay.
So if it appeared like infiltrating the vessel, and now when there is a complete resolution is there, the vessel is totally away. So we need not go back and resect the vessel. That defeats the purpose of the.
So that means the first imaging with the anatomy, say like the vessel anatomy, okay, the mesorectal fascia, etc. So everything is defined in the first anatomy, right? Dr. Govind, your patient is being started with imatinib. What are the counselings that you usually would do to these patients before the patient is being given the imatinib?
Yeah, one is in the pre-therapy thing. I find it useful to both, if it's a rectal, like the physical exam is helpful because it helps assess the response in a practical way from a surgical standpoint. That is a thing. And specifically for rectal, this may be one situation where I get an MRI, because assessing the response in relationship to the sphincter is much easier with an MRI. Now, in terms of informing the patient, they need to be aware that there will be some responders and some non-responders, and they need to be prepared for that, because they shouldn't be disappointed when they come out. And for a rectal gist, I still would tell them, most of the time you can avoid a temporary stoma, but if in the event of a difficult repair of the rectum, because it's not a standard LAR, you may still choose to divert. So I may tell them, look, there is a small chance that we may divert you, but it will be a temporary thing and we'll get it closed up.
Very, very important point, sir. Thank you. Now, Amit again. So as imatinib is the only drug that we have all decided upon, at least in this time, maybe 10 years down, we will have something else. What is the dose that you start with, and what are the tests that you do in monitoring the patients? So the next 6 months.
So, sir, usual dose is 400 milligram per day. It has to be usually given post meal because that reduces the gastritis of imatinib. Now, when it comes to monitoring of the patient, you should look into a couple of parts. One is, the toxicities of the drug, and next is the response to the drug. So, regarding toxicities, when we discuss of imatinib, usually they are, grade 1 and 2. Grade 3, 4 toxicities are very, very rare. But the common one are usually, the nausea, diarrhea, periorbital swelling, but then they are mostly grade 1 and they don't require treatment. One should be careful in monitoring liver function test of those patients when they are treated with imatinib. Rare lung and liver toxicity should be looked into. Sometimes it can reduce the phosphate levels, so we do monitor phosphate also. And when it comes to response assessment, we keep doing response assessment every 2 to 3 months because this is a neoadjuvant scenario, and we do follow this CHOI criteria rather than the RESIST criteria, because that gives you a better understanding whether there is a response or not. Because when we do give imatinib, initially the size may increase because of the intratumoral bleed, but that does not mean the patient is not responding. So usually they, even if the size is more but the density is reducing, you know, that's good enough, and you should follow CHOI. And when there is a good response to it, you know, you should keep continuing the imatinib till there is a maximum response possible. Usually that takes approximately 6 months of the time. And then, you know, we are happy offering those patients to our surgical colleagues to operate them upon.
Okay. So that means if you are monitoring the progression, your usual imaging should have been a contrast CT, because the CHOI is always on the contrast CT or the MR. Good. Now the question is, how long should you continue the imatinib before the surgery is done?
So, you know,
6
sir,
months, 3 months, 12 months, how long?
so, you know, the key question was whether we should operate them as soon as they become resectable, or we should wait more.
Yeah.
So that's the debate, like
That's the
in,
debate.
in most cases. So most of the, you know, there is no clear yes or no answer to that, but then it should be like, you know, if you choose a neoadjuvant treatment, you want them to shrink to their maximum limit so that the surgery becomes easier, the mortality of the surgery reduces, and the morbidity of the surgery reduces. Though there is a slight drawback. Suppose if you have, you know, patient was resectable, you kept on treating them, there is a slight chance of progression. But that's too little to be worried by medical oncologists and as well as by surgical colleagues. So we should continue them till they are, you know, maximum response has been achieved, and usually that takes 6 months. But then in most cases the guidelines say that don't go beyond 10 months or 12 months and then
maximum.
you stop, and yeah.
Right. No, the issue is that, Amit, that say in rectum, the policy has been changing. Earlier we used to wait around say 6 weeks to 8 weeks for after a long course radiation in adenocarcinoma rectum. Gradually the time has been increasing around, because lymph nodes that would appear large at the 6th week may appear to be decreased at the 12th week or maybe more. So is there something like that, that as you have mentioned, that when you start imatinib, maybe that the size increases? So is 12 months the optimum, or should the surgeon or should the oncologists wait a little more, maybe 12 months, 16 months, 24 months, something like that? Or
No,
say
sir.
at 12th months we stop imatinib and then tell the surgeon go for a surgery.
So whenever the say, you know, say maximal resection has been achieved and you do say a few more imaging after that, and you are not finding that it's further shrinking, that's the time to operate. Coming back to what you made a point, that was a bit different. You know, when you do a neoadjuvant chemoradiation therapy in rectal cancer, their radiation keeps acting beyond, you know, time. So usually they keep shrinking, you know, away from the radiation. So that's why you want to wait, say, close to 6 weeks and 10 weeks. Here in imatinib, that's the reverse. You know, when you know the imatinib was stopped in the adjuvant trial, usually recurrences are more 6 to 12 months after the stopping. So you don't want to be that late. You know, when the maximum safe resection has been achieved, you know, and you have stopped the imatinib, let the surgeon operate upon. That should be the concept.
Okay, so because the only evidence that is there in the literature is not that strong. The only evidence that is still existing is how long should you continue is around 6 months. But what I found out was that in August 22, that means this year, probably the first meta-analysis on neoadjuvant, what is interesting is that as you can see, ladies and gentlemen, they have only 7 studies. They took around 300 something and then they landed up with only 7. Out of them 1, 2, 3, 4, 5, 6, maybe only with rectum. Understandable, because we as surgeons will like to preserve sphincters. And they concluded that, as you can see the forest plot, that both OS and resection margins are better with a neoadjuvant imatinib. So that means now we have that credible evidence with us that it does work. Now with this, as I have said, that what will you do, Amit, if it does not respond? Because now when you come to Dr. Govind and Dr. Girish, because for the next couple of minutes, say, what will you do if the tumor rather than shrinking is growing up? When do you say that, okay, let me refer to a surgeon?
So, you know, if you have a molecular marker available and you thought that imatinib is going to work, and if the tumor is, you know, getting enlarged, you know, most probably that will be because of the intratumoral hemorrhage if the density is shrinking. So, you know, those cases will be pseudo-progression type of case. But suppose, you know, where there is no facility of doing those molecular marker and the tumor kept on increasing, the density of the tumor also kept on increasing, they are the primary resistant type of, you know, tumor which happens in 10% of all GIST.
How much does an MRI help? Because MRI shows you the cystic degeneration of tumors.
Yeah, and you know, that can also pick up, you know, or even the CT scan, good quality CT scan, if there is any new nodule within the tumor, that's a sign of progression. And, you know, even if it is not increasing or any new nodule within the tumor, you should be, you know, stopping imatinib and sending them to the surgeon as fast as possible.
So let us now have our two surgeons to talk about What is their experience on the 3 regions? Because time is short. Okay, it is a 45 minutes, so please, we will be ending around 10 minutes maximum. Now, so to start with Dr. Govind. Sir, your experience on neoadjuvant in stomach, GISTs.
So you are asking whether we've used it or?
Yeah, how many patients you have used?
So generally for the stomach, the
Yeah.
time I would use it is if it is very close to the GE junction. Otherwise, there is not really much of a need to use it. And I know that the first 3-month scan may not show much difference. But if I do start neoadjuvant, I tend to get a scan earlier so that we can have some idea. You know, if there's a small change, you may say it's treatment effect. But if there is a large growth, then you may change your direction. But ultimately, if it's a non-responder, you have to go ahead with the surgery because that's the only way. You know, it may be a bit more morbid, but you have to go ahead.
Okay, Dr. Girish.
Before any surgery, I'd like to stop the imatinib for at least 2 weeks. Very, very important because it's anti-angiogenetic. There is high risk of wound healing.
I was
and
exactly
leak.
coming to that, sir. Very good.
Leak. So that's why I would like to stop. No, I thought this point should not be missed.
Right,
so
absolutely.
that's why I
because
said.
I was going to come to that and I was going to ask Amit.
Oh, okay.
Because Amit is going to say that Ramanuj, imatinib अच्छा है, sunitinib बुरा है. Sunitinib is bad. Amit, are you going to say that?
I had
right. Yes, Dr.
I
Girish.
had bad experience with imatinib also. That's why even imatinib I want to stop it.
Right.
So
that's
then,
a very important point.
And in the stomach, again, 2 points as we earlier discussed: bad anatomy and bad biology. In both these, because sometimes, because stomach is a voluminous structure, most of the time the symptoms may appear very late. So when we are diagnosed, it will be really huge, and maybe sometimes occupying the whole left upper quadrant. We have seen such a bad ones. Well, we can't differentiate which is spleen, which is liver, which is left lobe of liver, which is pancreas. All is one mass, but still patient is happy, eating well, without any outlet obstruction, anything, not even lost weight, so like that.
No,
So
Dr.
we have
Girish,
seen
in these patients who have large GIST, say they come to you with bleed. Okay. Does this imatinib therapy help anyway in these bleeding GISTs?
Yes, it does help. But there may be sometimes a temporary rupture outside or inside. We may have to manage with sometimes percutaneous drainage. We have done one for one patient, had a subcapsular splenic bleed after starting the imatinib. So then we just managed with the percutaneous drainage. Most of them can be managed with the conservatively.
Right.
There is no need to
now,
operate.
coming on to a duodenal GIST, sir, or a periampullary GIST. Sir, your experience, because see, this Whipple's is a very morbid operation, whatever may be the experience of the surgeon. Because doing a pancreatic duodenectomy not for adenocarcinoma, but for a duodenal GIST. Now, sir, your take on that, Dr. Girish and Dr. Govind, and what is the thing that you will recommend if you are doing a...
Again, depends on the size and within the duodenum in the location. D1 or in the upper half of D2, lateral wall, we can still consider a local excision. When it is very close to ampulla or the lower ones, D3 onwards, it is very difficult to do a local resection. Sometimes we may have to resort to either Whipple or a pancreatic preserving duodenectomy, which is I have not done, so I have just a theory.
Dr. Govind, sir, any experience on duodenal GISTs or periampullary?
Yeah, so I think this is one area where I may, if it's a larger lesion, use neoadjuvant. Number one. Number two, if like Dr. Girish said, it depends on where, even circumferentially, is it on the lateral side or even is it on the pancreatic side? And then if it is beyond the ampulla, if you have enough margin to staple across the duodenum or the upper jejunum, you know, you may have to mobilize the entire thing, then you could staple and then do a duodenojejunal anastomosis. So you can do things to preserve, but some patients you just have to do the Whipple. There is no other.
Okay, because see the literature like borderline resectable is now something which mandates a panel discussion or maybe a oration nowadays. But GISTs getting into the portal vein, or etc. are not exactly very much described in the literature. So, sir, any experience or any anecdotes that you have heard or you have seen about Whipples with a large gist complication?
See, I think it doesn't directly involve the portal vein usually.
It
If it is
pushes
one
it
of
away.
those, yeah, it's pushing it, or like Dr. Girish said, it's involving every organ in that space. It's pushing against the pancreas, the duodenum, the
vena
stomach.
cava and everything.
Yeah,
Is it-
so there you have to be careful, but usually you will have a plane from the vessel because it's a pushing tumor, not an invading tumor usually.
Right.
Actually, Dr. Manisegaran, the other, he recently had a patient.
Yes, he was telling me.
He had actually shared this thing. They had a bleeding gist. They had to do an emergency Whipple for
So
the.
actually, that is the way that.
So he had shared, but
Sir,
we
in
didn't.
rectum, because time is short, rectum is something that, as you have seen, trials have been on rectum and rectum. Sir, your experience, both the surgeons, around what is your experience on organ preservation in these?
See, as we know, one is it depends on the location, very low or high up. Two advantages of neoadjuvant. One is preservation of sphincter. Second one is application of laparoscopy because they tend to be very large. When we offer them neoadjuvant and the tumor really shrinks, so without hesitation, without fear of rupturing the tumor, we can apply laparoscopic low anti-resection or whatever this thing can be definitely used in this scenario.
Okay, Dr. Govind, sir, your experience on this.
So I agree with everything that Dr. Girish said. I would also, since there are primarily surgeons in the audience, you need to be careful when you're coming across the rectum. Number one, if you're stapling it, especially laparoscopically, if you narrow the rectal lumen, it's going to leak. So you need to be very careful. And by definition, from the first slide, the gist is come from the wall of the bowel. So you need to be cognizant of that. Even though it may peel off, you may not have realized that there is a rent in the rectum. So I always advocate doing a sigmoidoscopy at the end of the resection to assess the lumen and the integrity of the rectum.
Sir, what about the mesorectum? Yeah, just 5 minutes, we are at the end. Any role for mesorectum or the TMEs?
No. I think it depends only if it is anatomically required. If it is pushing into the mesorectum, then you may have to get into the mesorectum and resect it,
Right.
but not for lymphadenectomy.
Yes.
Yeah, very well said, because non-anatomical excision of rectum is very difficult.
Exactly.
If you do
Because when
TME,
TME came,
TME
this is the way
becomes-
it made us easier.
Yes,
Because
yeah.
before TME, we used to have a lot of bleed around.
Yeah.
Right. So time is short. Experiences on bad gists in bad places, like omental and mesenteric. Bad gists. Sir, your surgical experience on these.
I know. I will one of my bad experience I'll tell. One patient has a stomach gist so huge, he bled both sides, intra-abdominally and intraluminally. He bled. That was the bad. We had to go in, and we could manage.
Dr. Girish, share your experience.
I think these kind of tumors, you have to, in the operative planning, you have to think of it like a sarcoma. You basically go around
exactly.
it and, isolate each organ, separate an
That is the
organ
reason
at a
I showed you in
time.
the first slide, that
Yeah.
Eniken's classification and the R0. Okay, Amit, an important thing, because we are now in the end, around 1 to 2 minutes maximum more. You see, radiation has been a great thing in rectum. There are trials and Stockholm trials and Hubbard gamma trials. But if the gist is that large, retroperitoneum or mesentery, things that surgeons, we cannot have an R0. Do you think giving radiation helps? I know this is a futuristic question.
I mean, it may, I don't know the right answer whether radiation should or should not, but at the moment it should not.
But
You should try.
sarcomas, it does create wonders.
Yeah, but at the moment you should try out with, imatinib, and if that fails, probably you should take that case to MDT, about thinking
Right.
about radiation therapy.
And so, Amit, to end up with, say neoadjuvant has been given, does it decrease the chances of a recurrence in any way? Because we did it everything so that we can attain an R0, spillage doesn't happen. But are there any upfront studies to compare the outcome of neoadjuvant versus upfront surgeries on recurrence?
Sir, I am not aware. Rather, even the adjuvant trial which concluded, the Scandinavian trial, they say that, you know, giving imatinib, you know, probably is making the cancer dormant for a longer period of time rather than increasing the cure rate. So there's a question mark till there are bigger studies, you know, being done, properly designed
Maybe
studies.
around 10 years down the line, again,
We
Amit will be
probably can
calling
have
you.
another panel discussion on that.
Okay, maybe again, because this is, as I've said, the last panel in this beautiful conference. This is future. So I think, ladies and gentlemen, we are at the end. We just maybe overstepped a couple of minutes. Sorry for that. But I think the summary should be that, as my distinguished panelists have said, that if you are planning into something called as a neoadjuvant for a GIST, what is interesting and important is molecular signatures should be done, maybe a must. Number two, particularly as both my surgeons have said, consider the anatomy and the possibility for a spillage and a need for an R0. Particularly in bad areas like G junction, large tumors arising from GIST involving organs, rectum, maybe periampullary, you should consider a neoadjuvant. And finally, always, maybe as surgeons, R0 is the standard of care. With this, I would like to thank my panelists, Dr. Govind, Dr. Girish, Dr. Amit, and definitely the whole team of IASG for giving us the opportunity to be in front of you. With this, thank you everyone. A very happy Diwali in front. Thank you, sir. Thank you.
Thank you.